All right, we're going to get started. I'm Dr. Gilliland. I am one of the transplant anesthesiologists, and I'm also a cardiothoracic intensivist, so most of my time with most of you will be next year in your third years, but we'll still work together a little bit over the next 12 months. We're going to talk about induction agents, near and dear to my heart, because these are medications that extend beyond the operating room, and a lot of the importance really knowing the limitations and the benefits of these meds are very important, especially if you're intubating outside of the OR where you don't have as much help, so you need to anticipate a little bit more how you're putting folks to sleep. So we are going to talk about techniques for induction of anesthesia. We will talk about the mechanism of induction for volatile and intravenous anesthetic agents, and then we'll talk about the pharmacology of common induction agents, benzodiazepines, propofol, etomidate, and ketamine. Those are kind of the big ones. A lot of textbooks will talk about thiopentol. Thiopentol is not available in the United States anymore because we were using it for lethal injections. So the people who make it won't sell it to us anymore because there are laws in their countries that say that that's unethical. So, intravenous induction. So, has anybody done an inhalational induction yet in the last couple of days? Really, the only time you're going to do this over here is if you bring a patient down from the ICU and they already have a secured airway. Or they have a tracheostomy, but even then, typically, we're giving a little bit of intravenous agent. So most of the inductions you're going to do here are intravenous. Most of the inductions you do over at Children's are going to be inhalational. Typically a combination. We really encourage synergism, mainly so we can avoid some of the negative side effects of some of the agents we use while still getting all the benefits. But part of that means timing is really important. So we talked the other day about you give fentanyl to blunt the sympathetic response. Well, if you give fentanyl at the same time you give propofol, the fentanyl's kicking in after the tube's already in, and you're not really doing yourself any good. So onset time is important. It seems like one of those little details that doesn't matter, but something to pay attention to. So for inhalational induction, these are useful in the absence of intravenous access. You also can maintain spontaneous ventilation, and it does typically encourage hemodynamic instability. So a lot of people we'll sort of combine this with intravenous. I had a patient the other day who had a very dramatic hypotensive response to induction with a previous anesthetic. So we gave him about half of what they used. And then once he was comfortable, cranked our CO up to 6, masked him down, got him comfortable before we gave our paralytic. So, these are not hard and fast separations. Again, all of this stuff is going to blend together, and it really becomes more of a finesse game when you're putting these folks to sleep. When you're thinking about an intravenous or an inhalational induction, you have to think about how confident you are with the airway, how deep you're going to get that patient, and are you going to be able to get access relatively quickly. So the downside of inhalational, you get somebody into stage 2, they laryngospasm, you have a big problem. You're thinking about IM sucks at that point. IM rock in adults is not really going to help you, but something to think about. And you can be limited by the agent. Really, the only inhalational agent we use for these types of inductions is sevoflurane. Desflurane, very irritating. Isoflurane just takes too long, and it also, people don't love that. So, on to our induction agents. It's going to be rare for you to do a full benzodiazepine induction anymore. Actually, when I was a resident, which wasn't very long ago, we used to do very heavy benzo opioid inductions for our cardiac cases. However, literature, especially in the ICU, that says these people suffer from delirium has really discouraged high-dose benzodiazepine use. Midazolam is a GABA-A agonist. It's short-acting. It's water-soluble. It sedates. You get anxiolysis. You get amnesia. And it's also an anticonvulsant. So you can use it for a bunch of different things. Some people use it for insomnia. You'll have people who come in who are on clorazepam. Obviously, they're going to be a little bit bigger dose when you're putting those folks to sleep. Alcohol withdrawal in severe cases will use benzo infusions, but usually Ativan, kind of PRN based on different scales that I'm sure you guys were very familiar with during your intern year. You can also use it to terminate a seizure. Fast onset, 1 to 5 minutes. It's highly protein bound, and there's a rapid distribution. So metabolism is through the liver. So in my patients, I can give 2 of Ativan, and it's going to hang around for a really, really long time. You have to be careful if you have a patient who's cirrhotic who you don't want to put to sleep for an 8-hour liver transplant, because these benzos are going to hang around for a while. The metabolites of midazolam are active, and they're excreted in the urine, and they're going to hang around again longer in cirrhosis, patients with congestive heart failure, obese patients, and the elderly. Organ system effects, so you get a decrease in cerebral blood flow and cerebral... Do you guys get this?
Yeah.
Okay. Eventually I'm going to give this lecture and people aren't going to laugh and it's going to make me really sad. Impairs your physical and mental abilities up to 24 hours. So when you're consenting a patient, hey, maybe don't make any major financial decisions, operate heavy machinery, be nice to your... Sorry?
Is that what you got?
I mean, presumably, a kid getting dental work, usually some benzos, usually PO, midazolam. You'll give like massive PO doses to kids over at Children's. It's kind of interesting. From a cardiovascular standpoint, mostly cardiovascularly stable. You are going to get a little bit increase in heart rate, a little bit of a drop in SVR. That's really based on the anxiolytic. The SVR is anxiolytic. The heart rate portion is more reflexive. You get it depressed CO2 responsiveness. However, if you're doing sedation and all you're giving is Versed, generally you're going to be able to maintain an airway. If you give a bunch of Versed and then you give a little bit of fentanyl, they're going to stop breathing. So you have to be very, very careful when you give synergistic agents. Benzodiazepines do cross and enter fetal circulation, but it's unknown whether they're teratogenic, so it's just something that we're very careful with. Lorazepam, Ativan, relatively long-acting. You're really not going to see this in our ORs except for liver transplant. So relatively long-acting, far more potent amnestic than midazolam. Also metabolized by hepatic microsomal enzymes, though the metabolites are inactive and they're excreted renally. As you can see, the elimination is significantly prolonged compared to midazolam, and it does that is increased in the elderly. And this is the one that so the major studies looking at delirium and benzodiazepines in the ICU were focused around lorazepam, called the MENS trial. Yes.
So Versed, can you use that in patients with like really bad kidneys because of the active metabolites that are treated in the urine, or does that not really have a clinical?
You can, but generally, it redistributes in their total body volume, and by the time you're looking at waking them up, it's not a big deal. Most of the clearance and metabolism issues that you run into are if you continue to give large doses, so you just have to dose adjust for those patients. But yeah, high incidence of ICU delirium in patients treated with lorazepam, continuous infusions, and PRN, which led to higher morbidity and mortality. So not a lot of Ativan outside of alcohol withdrawal. Propofol, our old friend, water insoluble, formulated in 1% lipid emulsion, rapid onset, rapid offset. It's also a great rescue antiemetic. It's one of those things that impact you if you've given everything. You've given your compazine, your Phenergan, your Zofran, your antipsychotic, and your benzo. A little bit of propofol goes a long way to kind of reset people. Obviously, don't give them so much that they can't protect their airway and they aspirate all that vomit. But something to be aware of. There is some injection site pain that's mitigated by lidocaine. There's a lot of discussion over how lidocaine works in that situation. Does it actually have local anesthetic effects at the injection site? Does it change the emulsion that it actually goes into, and that's what reduces the stinging? So kind of interesting. Organ system effects, stimulation of GABA. You can get unconsciousness within 1 minute of your induction dose, and you don't get a lot of excitatory effects, though you can see some myoclonus. It makes the nurses nervous, but if you've seen it before, you know what it looks like. You say, no, it's fine. They're asleep. It's going to be okay. You can get dose-dependent decreases in your systemic vascular resistance and impaired myocardial contractility. So this is one of the medications as an infusion that our cardiac surgeons don't particularly love in their postoperative patients, though that is kind of institution-dependent. Where I did fellowship, we use this for everybody coming out for a post-op heart. You get dose-dependent respiratory depression and decreased CO2 responsiveness. Doesn't really have a lot of effects on other organ systems. It's a really nice medication that way. It's a great rescue medication for a lot of things. So we were talking Sorry, I'm going to point at like the same two people because we worked together the other day. It's a great little rescue medication if your patient starts moving or bucking. If you give rocuronium, it's going to take a few minutes for that to kick in, and the surgeon's going to yell at you for all of those 2 to 3 minutes. If you give them a little propofol, you pop them off the vent, you try to decrease stimulation, it's going to kick in a lot faster. It's going to let your longer-acting medications time to work. Give a little fentanyl, give a little rock. You're going to be in a good situation. Only anesthesiologists should give propofol. That's just kind of, you guys know that, but cardiologists giving it PO, not particularly effective. Propofol is lipid soluble, has a very large volume of distribution, which is why it comes off so quickly. For excretion, you have glucuronide and sulfate conjugates. You can get some green tinged urine, sometimes white tinged urine. So if you're doing a long TIVA, you can see a change in the character of the urine. It's nothing to worry about. They don't have pyuria. They don't have some horrible infection. It's just you. For dosage, you're looking for a blood concentration 2.5 to 6 micrograms per ml for major operations, 1.5 to 4.5 micrograms per ml for minor operations. Those numbers aren't important. It really is titrated to effect. You should just sort of have an idea of what you're shooting for. For induction, 2 mg per kg is pretty standard. You can go a little under that when you have other synergistic agents on board, fentanyl, Versed, lidocaine. Again, timing dependent. A little ketamine goes a long way. And for infusion, for TIVAs, you're looking somewhere in the range of 100 to 200 mics per kg per minute. Etomidate is my least favorite induction agent. Though a lot of people use it as sort of a get-out-of-jail-free card, which is one of the reasons why I don't like it. Rapid onset and offset. It's a 0.2% solution with 35% propylene glycol. This really burns. You think propofol hurts when it goes in? Etomidate really hurts when it goes in. So be cognizant of that. Make sure your patients know that this is going to sting. Binds GABA at the beta-2 and beta-3 subunits. So you get neuronal hyperpolarization, depression of the reticular activating system, and then you get inhibition of neural signals. Organ system effects, this is why people like this. So you get cerebral protection with decreased cerebral metabolic rate. You can trigger grand mal seizures, so you have to be a little bit careful in patients who have a history of epilepsy. Causes hypnosis, causes sedation, does not give you any analgesia, so you definitely need adjuncts for these patients. Has anybody seen an etomidate infusion? So nobody's done an etomidate infusion in like 20 years. So this is where all the initial literature came out with adrenal suppression. Because etomidate was so stable, and it doesn't really affect your cardiovascular system, we would use it as infusions in ICU patients. What we found, and what we'll talk about on the next slide, is that you get pretty significant adrenal suppression with those patients. But you can maintain spontaneous ventilation with infusions. However, if you give more, like an induction dose or a synergistic opioid, you certainly can cause apnea. The other place that this is really useful, and it probably won't be something you guys do as residents, unfortunately, this is something I found out once I finished, very small doses for sedation for things like TE cardioversions. So they keep breathing. These are always like very low EF, very sick patients who you don't want to give propofol to. You don't want to give a bunch of pain medications to because after they shock them, they're not going to breathe. Really small doses of etomidate until they're nice and comfortable before you shock them can be very helpful. And again, minimal cardiovascular effects. Almost anything you use is going to drop your SVR to some degree, only because you're taking somebody who's awake, who's anxious, who's really hyped up, and you're taking that away. So unless you're actually augmenting SVR and heart rate for some reason, you are going to see a drop. Big downside of etomidate and why I don't like it very much is you get corticoadrenal suppression. So you get inhibition of the function of 11-beta hydroxylase. Maximum effect is at 4 hours, resolves usually around 24 hours. You get increased mortality with etomidate infusions. That said, in patients who are septic in particular, single doses can cause a significant enough adrenal suppression to put you into crisis. So you need to be very, very careful with these folks. Higher degree of myoclonus than you see with propofol. because there's an imbalance between your inhibitory and stimulating signals in the thalamus and the cortex. You see this in 30 to 60% of patients. High incidence,
In an otherwise, healthy or patient that has like some heart issue that you may use etomidate for, but otherwise they're not in sepsis or anything, would you still prophylactically give a steroid? Like, would you assume that everyone's going to get improved suppression with it, or?
I mean, most people are getting steroids anyway for post-op nausea and vomiting, so it's sort of outside of that range. I would say in an otherwise healthy patient who has a cardiac issue, there are other medications that we can use. Some of my cardiac colleagues would disagree with that. We're going to talk about my favorite medication here in a little bit. But certainly you have to think about where these patients are going, what they're having done, especially for cardiac surgical patients. Those are folks who land in the ICU for several days and have a number of complications afterwards. So my general feeling is, unless it's an emergency and you need something that's going to be stable right then, the nice thing about etomidate is it's not a controlled substance. So you're going to see etomidate in a lot of the airway bags because you can't have a vial of propofol in there that you then have to account for. Same with Versed, same with any of your opioids. So it's a nice rescue medication because you can grab it and you don't have to necessarily worry about a lot of red tape. And because at least in the initial stage, you're not going to have a lot of cardiovascular issues. But one of the things I would really encourage you guys to do, right now you're learning how to get people to sleep, keep them alive, wake them up, like basics. As you progress, I want you to think about where these folks are going, what your treatment looks like in the context of their overall care, how your treatment, your care of them for 3 or 5 or 8 hours is going to affect what they look like for the next days to weeks, which is why I always kind of hammer on etomidate. High incidence of post-operative nausea and vomiting. So if anybody has a history of PONV, would strongly discourage the use of etomidate. And then porphyria is one of those things that likes to show up on your basic exam and on your advanced exam and on your oral boards. So just something to kind of keep in mind. Distribution, 99% in a non-ionized form in the plasma. 75% protein bound, highly lipid soluble. So again, large volume of distribution, kind of similar to propofol. Rapid action, rapid offset. You have an increased duration of action with renal or hepatic dysfunction. It is metabolized by ester hydrolysis and eliminated as inactive metabolites in the urine. Your induction dose is going to be around 0.3 mg per kg. Should see loss of consciousness within about 2 minutes. And of course, it is synergistic with benzodiazepines and opioids, so you can decrease your dose a little bit. This is my favorite. I love ketamine. I would give it to everybody if it wasn't on shortage. I'm always fighting with our pharmacists because they try to limit it to the OR, and it makes me sad. Ketamine is metabolized in the liver and 91% excreted in the urine. It was designed as the perfect anesthetic. It is a battlefield anesthetic. You can give it IV. You can give it IM. You can give it sublingually. You can take it PO. It's fantastic. You get very potent analgesia. You get loss of consciousness. You can get immobility. You get amnesia. It's really wonderful. There are some side effects you have to mitigate that we're going to talk about. But in general, Special K is fantastic. One of the reasons why it works so well is because it's really dirty. And it hits all these different receptors. So you get NMDA antagonism. This is the primary one. So calcium, sodium, and potassium channels, glutamate receptors. You get local anesthetic effects. Phencyclidine receptors. So people who test positive for PCP, sometimes it's actually because they've been using ketamine. Hits mu, delta, and kappa opioid receptors and inhibits epinephrine, dopamine, and serotonin reuptake, so those stay in the synapses longer. It's great. It's just the best. Organ system effects. You do get a little bit of cerebral vasodilation, so you have to be worried about people with intracranial masses, head bleeds, things like that. There is some data that says it's probably not as bad as we think it is or as dangerous as we think it is, because especially if you're using it as an induction dose, you're putting a tube in, you're hyperventilating, and the effects are pretty short term. Emergence delirium is really the thing that we worry about. So people with a history of PTSD, probably not a great idea to give ketamine. Also, elderly patients, you just have to be cognizant of what you're going to do. This is generally mitigated by benzodiazepines. But again, if you have a patient population that you're not using benzos in, you have to be a little bit thoughtful about whether or not you want to use ketamine. You can get an increase in SVR, cardiac output, but also myocardial oxygen consumption. So you have to be a little careful. Patients who have lesions that are not revascularized yet, somebody coming in for a CABG, for example, maybe not a great candidate for ketamine, although there are mitigating factors for that. Great for awake fiber optic intubations. So you maintain airway patency, maintain spontaneous ventilation, you get bronchodilation with ketamine. So if somebody's bronchospasm in the OR, you can think about giving them a little of this as an adjunct to whatever else you're doing to treat it. However, you can see upper airway collapse and apnea with other agents, just like anything else. One of the things to keep in mind is it is a sialagogue, so you are going to have a lot of saliva if you give somebody ketamine. So when you're thinking about using this for an awake fiber optic intubation, pre-treatment with a little glycopyrrolate can go a long way to keep them dry. It's also going to keep that heart rate up a little bit. Clinical uses, we keep finding uses for ketamine. There are ketamine infusion clinics where you can go if you're depressed or you have chronic pain, and they'll put you in a chair and hook you up for a few hours. We use it for perioperative and postoperative pain management. We use it for chronic pain, in chronic regional pain syndrome, patients with fibromyalgia. We actually think it might be neuroprotective for ischemia reperfusion injuries. It's also very cheap, which is one of the reasons. And because it's a non-opioid analgesic, there's been a big push, especially in the opioid crisis, to use more ketamine and to spare some of the opioids that we typically use.
We haven't put as why it's your favorite.
Because it does all those things.
It just really, okay.
Yeah.
Obviously, like some sort of CB related.
So one of the things that I didn't mention, and I didn't do it intentionally, or I did do it intentionally, is some people say that if you are very catechol deplete, that you can get direct myocardial suppression from ketamine. The data is very weak, but that's what you're going to read in textbooks. And I'm going to give the same caveat to ketamine that I give to every other medication. While in theory, you should increase your cardiac output, you should increase your SVR, that's generally in pretty healthy patients that are not in extremis. If you cause a sympathectomy in somebody who's really worked up and who's in respiratory failure in the ICU and is sweating and freaking out, and you take all that away, they're going to drop their blood pressure. They're going to do all the same things that these other patients do. But in general, it is a little more stable agent, certainly than something like propofol. And you may avoid some of the long-term side effects of high-dose benzos. This is just a slide for your reference, because these are the things that they like to test on in written boards. This is going to be in just about any textbook that you find. But it's a nice way to sort of keep these things straight in your mind. Yes?
The connection to porphyria, is that it causes it or unmasks it, or what's the...
It unmasks it, so people who are predisposed. So generally, you're not going to have somebody who doesn't have a history, or at least not a known history, who's going to have an issue. But I had an oral board stem that had a patient with a history of porphyria, and it was like very specifically, what would you not give this patient? Thiopentol also does that, but because they don't really test on that anymore, it's less of an issue.
What is methohexatol? I read about that a couple times. What's kind of that use case context?
I've never used methohexatol. I would actually have to go back and read about that because I haven't heard methohexatol in a long time. But that's a great question. I'll try to include it. Have you guys used it?
Do they use it for the seizure?
Yeah.
Oh yeah, that's right. Drop seizure threshold for. That was the last time I used it.
That's the only time I've seen it.
Yeah, and usually we only do that. I've never done one of those here. We do it at the VA for the shock therapy, ECT.
The refractory depression. Yeah, other than that.
Yeah. You give them a bunch of different agents to try to.
XL doesn't raise the seizure threshold, it drops it.
Right.
Interesting, even though it's a barbiturate.
Yeah, it's a little strange. But that is one of those things that's good to know, and I'm glad you brought that up. That's one of those things that they like to test on because it's one of those funny little differences. Any other questions, guys?
How much of a dose would you give for nausea and vomiting with propofol?
Really, really small doses, 10 milligrams, 20 milligrams. Remember that these are generally people who came out of anesthesia and still have a little bit of anesthetic on board. So you're not going to have the same effects as somebody who's awake and hasn't seen anything. So you are going to see a little bit of synergistic effect. And it's something that only you are able to give in PACU. So you can't tell a nurse, oh, they're really nauseated, why don't you give them 10 of propofol or 20 of propofol? Most of these agents are meds that only we are able to administer with the exception of benzodiazepines, just because nobody else has the training or the comfort level with these drugs.
And after a general, let's say you have a really minor procedure and you have a general anesthetic for it, and you just have propofol rock and a little bit of gas. How long does it take for those effects to fully wear off? You have the same day discharge with a minor procedure. I'm just curious.
It's really dependent. So it's dependent on organ dysfunction. Otherwise, a couple hours. Yeah. Usually they'll observe. You guys haven't really. None of you have had a PACU rotation. There's scoring systems based on level of consciousness. Ability to maintain your saturation without oxygen, pain, nausea. So it's really the actually being aware and communicative is a very small part of what we take to keep people here. Inability to void for certain procedures is a big reason to keep people in-house. So, but usually, otherwise healthy person, a couple hours, you can get them out of PACU. Sound good? All right.
Thank you.
Thanks.
Do PBLD this afternoon.
Great. Is it here?
I believe so. I need to look at the room.
Thank you.